I'm delighted to invite our next speaker, Professor Danielle Mazza, who will provide some insight on how to balance clinical and research work alongside your life at home. So Professor Danielle Mazza is the head of the Department of General Practice at Monash University and is a recognised leader in the implementation research and knowledge translation in the general practice setting. She has made significant contributions to advance general practice and primary healthcare in Australia in women's sexual and reproductive health, and as an advocate of evidence-based quality improvement through guideline development and implementation. Please welcome Professor Mazza.
Okay, good morning everybody. I'm delighted to be here. I wish I'd had the opportunity to attend a day like this through my medical training. I trained at Monash University, and I didn't know that you could become a researcher, really. And when I entered medicine, I thought I was going to go into clinical practice. And while I did, I've had such an amazing opportunity and privilege to work in research, and I hope that I can pass on a little bit of that passion to you today. And so I also, like Sue and others, would like to acknowledge the people of the Kulin Nations on whose land Monash operates, and pay my respects to their elders past and present and emerging. So a bit about me this morning first, before I try and give you a few tips and tricks about things that I wish people had told me earlier on in my career. Currently, I run the Sphere Centre of Research Excellence, and it's got a bit of a long title, in women's sexual and reproductive health in primary care. So I've been very fortunate to work with my colleagues on this venture, which is now in its second iteration. So we got 5 years of funding from the NHMRC first up, and we must have done a good job because they gave us another 5 years worth of funding. And what we do is we do health services research. And the two previous speakers that you've had do different kinds of research to what I am involved in. So health services research looks at system kind of issues that help to deliver medicine in a much more effective way. So the kinds of things that we're looking at is how do you build system and workforce capacity? How do we train our health practitioner workforce to be able to deliver the skills and the care that's required? How do we address consumer needs? And how can we use the data that we've got to actually advance the field? And so my research cuts across different kinds of spheres as in my research centre, but our research tries to do three things. We try to work very closely with government to inform policy and get better policy outcomes to enable better care in the community. We also want to help improve health literacy of our patients, to empower them to be able to get the kind of health care that they need. And finally, we also need to improve clinical practice, and so we work with health practitioners in the area of generating new clinical evidence, developing guidelines and helping practitioners to actually implement those guidelines. So hopefully through those kinds of three strategies, we actually will achieve better outcomes for women. So when honours students come to events like this or are thinking about doing honours, they often think about lab-based honours years, and I say to them, we don't slice up sheep's livers, we don't do tests, with equipment and stuff like that. We are out in the community asking questions, talking to people, gathering data, and feeding that back to people of influence, policymakers, consumers, and healthcare practitioners. And I guess my research journey really started out from very pivotal experiences in my career. And I think I was thinking when I was driving here, which one of those was I going to talk to you about today? And the one that came to my mind was a young 17-year-old girl who I cared for as a resident in the Dandenong Hospital who was in labour. And this girl was in the labour room by her... I'm going to start crying even thinking about it. She was in the labour room by herself, in labour, and she was strangely silent. She was in quite a lot of pain, and I remember her kind of curled up on the bed in this kind of fetal position on her side, going through very intense contractions on her own, silent. And her story was that this was an unplanned pregnancy. She had been kind of ostracised by her family, had no social supports, and there was a question about whether she was going to give this baby up for adoption or what was going to happen to her. And I guess, you know, we all, for those of you who are training in medicine, you see these kinds of scenarios that really touch you deeply and you want to do something about it. You think, how did that girl get into that situation? What are her circumstances? And me delivering care to her is so temporary. You know, I can help her with the labour, I can help her with pain relief. But what happens to her life? How did she come to be in this place? And, you know, through my research, through my clinical practice, I've seen a lot of the socio-demographic impacts that, influence women's health outcomes. The extent of violence experienced by women, child sexual abuse, lack of educational opportunity, stigma about women's health conditions, the feeling that a lot of women have that they're not heard when they are interacting with the healthcare space. And so these are all of the kinds of issues that I want to address. And some people think, oh, general practice research. What's general practice? How can you do research in general practice? Well, in fact, general practice is the intersect between all of the public health and population health aspects and how that actually impacts on the individual. And it's impacting on all of you and your lives. Your health is in a way a product of your background, your ethnicity, the culture that you're growing up in, the impacts of whether you come from a well-to-do family or a less well-to-do family, what traumas you might experience in your life. And so the care that we deliver in general practice has to respond to that. But we can only deliver that kind of care if we're supported by government and our healthcare policies to do so. So that's kind of where I work, and I'm so privileged and honoured to be able to work in that space, because for me, doing medicine was about trying to make a difference. And I realise in clinical practice you can make a real difference with individuals, but if you really want to magnify that impact and have greater influence, research is an amazing career to be able to do that. So sorry, that was a bit long-winded. So I work in the space of reproductive rights, and this is all about helping people to have the number of children they want when they want them. And so in order to achieve that, you've got to have access to effective forms of contraception to prevent pregnancy. You've got to improve access to safe abortion services where that's required for an unintended pregnancy. And you've also got to improve preconception care to enable the best possible outcomes for the children that you do have. So these are the clinical areas that I work in, and I want to give you some examples of how our research has influenced policymakers and consumers and health practitioners. So a lot of what we do in Sphere is actually about making things transparent. So this is a very stigmatised space, contraception and abortion. So it's very powerful to present data to people. And what's been very influential when I speak to policymakers is to talk about what's happening in Australia and then compare it to what is perhaps best practice or what's happening internationally. And the availability of long-acting reversible contraception is exactly one of those areas. So long-acting reversible contraception, if you haven't got to that stage of your medical training yet, are IUDs and implants. They're the most effective forms of contraception that we have that is reversible. But because they require an insertion procedure, they're a little bit more complicated than, going and getting a prescription for the pill. And uptake in Australia is unbelievably low when you compare to other countries, and I've given you some examples there, like the UK and Sweden and Denmark, where hormonal IUD use is sitting up at 35%. So, I took our data and I went and I spent quite a lot of time actually talking to Jed Carney about this. And one of the reasons why LARC uptake is very low is because women aren't being offered it. They're not being told about it. So a lot of the work that we've recently done has been about, if you change women's knowledge, does that change their preferences? And if it changes their preferences, does that lead to increased uptake? So how do we get GPs to better counsel women about these options? Where can they find this information? And what does that actually mean? We created these nice videos, we've translated them into different languages, and we've put that out in the field and tested that with research and found that increased knowledge does lead to increased preference for IUDs and implants. But the uptake is more difficult, and that may reflect the fact that they're encountering barriers to getting those kinds of products. So we thought, well, how do we improve uptake through general practice? And this was one of the first NHMRC projects that I ever got funded for. It was called the Accord Project. And here we tried to increase uptake of LARCs through a general practice intervention. And it was a complex intervention in two parts. It had online GP training about effectiveness-based contraceptive counselling, and we had a mechanism for GPs to book an appointment then and there on the spot. If women said they wanted an IUD, the GP could book them an insertion appointment with a local gynaecologist if the GP didn't do that themselves. And you can see from our results there, and I've put big circles around them, that when you compared the control practices to the intervention practices, we got a massive uptake in IUD and implant utilisation by our patients. And if you compare that to the 11% that I showed you before, here we're sitting up at 12 months at about 46, 47%. We followed up those women 3 years later, and they're still using those products, and we demonstrated that there are fewer unintended pregnancies and abortions in that intervention group. So this was the first Australian-based research to demonstrate that if you invested in an intervention in the general practice setting, you actually got an increase in LARC uptake. So I'm very proud of the fact that this research has led to very clear policy outcomes. And I've worked closely with government through my role on the National Women's Health Advisory Council to tell them about this kind of research. And in the package that was announced in February, there was I don't know if you're aware, there was a $750 million, do my maths right, package in women's health announced by the Health Minister that involved a whole lot of interventions that had stemmed directly, I think, and supported by others from some of the work that we did within Sphere. So increased Medicare rebates and bulk billing incentives to incentivise GPs to deliver these services, training scholarships to provide the education like we provided in the Accord trial. Centres of excellence are about to be established to increase training opportunities, and there's been others as well They're going to develop a contraception decision-making tool, and there are new products in the contraceptive space that have come onto the PBS for the first time in 30 years. So I think this is a real boon for women's health and a direct result of research coming into policy and affecting policy outcomes. I'll give you another example of making data transparent to policymakers, and this was a study that we did back in COVID times. So I don't know if you're aware that there are two options for how you can have an abortion. You can have a medical abortion or a surgical abortion. And medical abortion is undertaken with mifepristone and misoprostol, which in Australia is packaged up into a product called MS2-step. And it's registered for use up until 9 weeks gestation. And because of the stigmatised nature of abortion and because of politics, and you're probably all too young to know about a guy called Brian Harradine, who was a politician from Tasmania, who did a deal to try and suppress abortion access in Australia. When mifepristone was registered, it was subject to enormous barriers for practitioners, which actually increased the stigmatised nature of delivering this service. So GPs were required to undertake mandatory training and certification and recertify every 3 years if they wanted to prescribe medical abortion. Pharmacists had to also do this mandatory certification if they wanted to dispense medical abortion. And this is quite different if you think about other drugs that GPs prescribe, Panadine Forte, opioids, other things that are very dangerous products. You don't need to do mandatory training and certification for those products. So we wanted to demonstrate what the impact of this bad policy was. So we put on a map, we looked at PBS data and we put on a map where medical abortion was being prescribed and dispensed. And this was in 2019. And all the yellow areas on that map were areas where not even one GP or one had prescribed or one pharmacist had dispensed medical abortion during that year. And you can see, look at the eastern seaboard where most of Australia lives. Look at Brisbane. Look at Western Victoria. I was talking to Sophie about this before. This is pretty scary stuff, that women aren't able to actually access this kind of essential health service. And we demonstrated about 30% of women lived in a statistical area where this product hadn't been prescribed. So I had my colleague Karen Price, who was president of the College of GPs at that time, and Karen got me a meeting with Greg Hunt. This was during COVID, and Greg Hunt was fantastic. He looked at this data and he said, we've got to do something about this. This is really not good. And in July 2021, he introduced MBS item numbers for telehealth sexual and reproductive health consultations. And this enabled, for the first time, remote access to medical abortion for the women of Australia with no patient restrictions. So if you've been to a GP and used telehealth, you'll understand that in order to claim a Medicare rebate, you have to be a patient of that practice, you have to have seen that practice face-to-face in the last 12 months. Well, these sexual and reproductive health items don't have that restriction, right? So this enables a woman who lives in WA to get an abortion from a doctor in Queensland remotely through medical abortion. And this was really transformative change. Our research also led, and we were able to utilise research from Canadian colleagues to demonstrate that these regulatory requirements, certification and training were really bad things. that blocked access to care. And our colleagues in Canada had demonstrated that if you deregulate medical abortion, safety is maintained and access goes up. So I was able to bring that evidence to the TGA, to Jed Carney, and say, you know, what are you going to do about it? In 2023, those requirements were removed and medical abortion became deregulated. And now, if you press stone, it's the same as prescribing any other drug that a GP does. It's your professional responsibility to train, to deliver the care and to utilise that medication where you see fit. And there was also deregulation to enable, for the first time in Australia, nurse practitioners and midwives to be able to deliver this kind of care. So all fantastic for access. So I guess these are some examples of the way that research can directly impact policy and bring about better outcomes for women in terms of access. And some other projects that we're doing, in case you want to come and do some work with us, some research with us, we run other programs that are NHMRC and MRFF funded. Our AusCAPS network of community of practice is an online community where we're supporting primary care practitioners to deliver LARC and medical abortion. We're trialling in general practice new models of care. Nurse-led delivery is our, in rural areas of Australia, is our Orient trial. I've just looked at the preliminary results and they're pretty exciting. I'm going to be sharing those with government soon. Our Alliance trial is looking at counselling pharmacies, community pharmacists, to deliver better contraceptive care. We're also doing some work in endometriosis management and how to implement guidelines in practice. And we're very involved also in ongoing advocacy. We have a Sphere coalition that people are welcome to join, where we gather together to talk about policy and practice issues, develop consensus statements and what we can do about that. And we put in submissions, and this was our submission to the Universal Access to Reproductive Healthcare Senate inquiry, which was also very influential in bringing about policy change. So that's a bit about the research and how research works at that kind of policy and practice interface. I thought you might be interested to hear about my journey to research. I was telling Sophie that it's really serendipity in a lot of ways. You know, my dad, when I was growing up, he used to drive me to ballet lessons on a Saturday, and he used to give me this big lecture, you know, Danny, you've got to do medicine, it's really important, it's be a wonderful career. You know, we in the family, we never had the opportunity to do medicine. It's your duty. I'm the daughter of migrant parents, so, you know, it's your duty to become a doctor. And thank goodness he gave me that advice. My beautiful father, what a wonderful career it's been. But very pivotal moments for me in my journey. I was always interested in women's health. I did an elective with Wendy Savage, who was a trailblazer in London, whose patients marched the streets for her. She did obstetrics differently, and she opened my eyes to challenging dogma and looking for the evidence. I did a graduate diploma in women's health with Lorraine Dennisteen, a similar trailblazer in psychiatry. Lorraine's area of research had originally been in the psychosomatic impacts of hysterectomy for women, and she also did a lot of early menopause research. I did an academic registrar year in my GP training, and then I couldn't believe that you could be an academic and you didn't have to clock on and clock off, and nobody really watched over what you did. And you got paid to go to travel and go to international conferences and meet really interesting people. I thought, this sounds good. And then then became Medical Director of Family Planning Victoria and really got a lot of clinical experience there that sent me on my way. I ended up writing a textbook on women's health that's been translated into Chinese, and I went over to China for that launch. I've had a couple of babies on the way. My mother said to me, when I said, "When am I going to have a baby, Mum?" And she said, "Well, why don't you do it while you're finishing writing your thesis? You know, the baby will sleep and you can write your thesis." Ben never slept. I only came back into academia. I was outside academia. I only came back into academia really after my return. I did a couple of years in Malaysia. So my career in research has really only taken off, I think, since, I don't know, since I was 40 or something, in the last 20 years or so. So, you know, my advice there is just take whatever opportunities come. You don't know where they're coming from sometimes, and your career goes in different directions, but just follow your passion. Find a good mentor. Early on, I was advised to seek out one particular person as a mentor, and I went to have a meeting with him, and I remember distinctly feeling quite uncomfortable in that room, and him telling me, "Oh yes, Danielle, I'd be very happy to be your mentor, but I've got to tell you what the ground rules are, and the ground rules are that if I say jump, you say how high." And I ran out of that office and stayed away from that guy as much as I could. And there are some really toxic people that you really need to not be around. But I've been very fortunate to have different mentors. I worked closely with Michael Kidd, who's now the Chief Medical Officer, John Murtagh. You know, even though we may have differences in opinions about a lot of things, he's been wonderful to me. I sought out the advice of Kate Carnell, who's an ex-politician. She was the ACT Chief Minister, and asked her to mentor me at one point when I was just coming into my leadership role back at Monash, and she gave me some really good advice about dealing with difficult people. She said, "Danielle, when you go into a meeting with a difficult person, just look at their forehead and think MMFI, MMFI." So I've told my kids that, and sometimes they say to me, MMFI. Do you know what MMFI stands for? It's make me feel important. So that was very good advice. But yeah, find yourself some good mentors. Learn the tools of your trade. So I supervise quite a large team now at Sphere. And one of the critical things that you know, research is all about communication and communication skills. How do you write? How do you do public speaking? How do you give that kind of pitch to people when you've only got a short amount? How do you connect with people? How do you convince people? You've got to learn how to do all of that as much as you've got to learn how to do statistics or qualitative methods. Very important to learn all those skills. And if you're thinking about a PhD, I tell my colleagues that in my department, try and do a PhD early on in your career. It's really, in terms of academic progression, it's really a big hurdle, particularly for clinicians, you know, and general practice has been much slower, I think, than other disciplines in encouraging research careers. And I find that, you know, trainees, they go through medicine, they do their hospital rotations, they do their general practice training, and for women that are, you know, it's mainly women who are interested in my area, they hit 30 and they've just finished their GP training, 31, 32, and they want to have a baby and they want to buy a house and they want to start their families. And I'm trying to tell them to do a PhD in the middle of that, and they just look at me like I'm crazy, and I am crazy, but I think if they want to come into academic work, you really need to have a PhD behind you. Work in a happening place. I'm very fortunate. Monash Department of General Practice is a fantastic place. It's really come from a very strong education background with Leon Pitterman and John Murtagh and Michael Kidd, and I've been able to help grow the research. I also think you need to create your own peer support network. When I was doing my MD, I did a clinical doctorate. I actually did that at Melbourne Uni, and my colleagues there were Jane Gunn, who's now the Dean of Medicine, Nairi Curse, who's also done very well working in New Zealand. I can see Sophie standing up, so I'm just going to go to the end and say another critical issue, I think, is to understand how promotion works in the academic system. This was another area that was very non-transparent when I was going through. It's important to understand that when you're doing something like your PhD, you're also planning for your next steps, and you can't plan your next steps when you finish your PhD because you'll already be behind the 8 ball. So always think ahead, and think ahead what's needed to move up to the next level. When you're a research fellow, you need to start having national affiliations, national involvement with your college, with your discipline, with other relevant organisations. As a senior research fellow running major programs, as an associate professor, you have national recognition, so you become the chairperson of the committee, and then so when you put in your promotion to go to professor, you've got international recognition. It's really important to understand how this all works, and hopefully your mentors are telling you how to do that. Also important to really look after your mental well-being. I listened to Sue, what a lovely presentation she gave. For me, I know what keeps me sane. I dance, like I'm going to my dance class this afternoon at 2 o'clock, never miss that. My dog, the beach, my garden, my bike, they're all the things that I love to do. If I don't do them, I get sick, I get unwell, I get stressed, I get grumpy. So my kids are very important. Mum, you're not smiling, go dancing. Okay, I come back with a big smile on my face. And if you're a wicked Jezebel feminist or you love family planning, consider coming to do some research with us. If you believe in reproductive rights, if you want to get better health outcomes for women, it's been a wonderful journey for me, and I hope you similarly find your passion, and I'm sure it'll be a wonderful journey for you. Thank you.
All right, thank you so much, Professor Mazza. That was really interesting. I think that's definitely something that I didn't know you could do research in GP either. So we've got time for questions if people have questions. I mean, I might start with one if that's okay. So it sounded like having mentors is a really important part of, I guess, getting through this career and finding new pathways and things. Do you have any advice for junior people like myself or other people in the room about finding mentors who might have the capacity in their daily life to actually provide that mentorship? I'll just give this.
Yeah, so mentorship is a strange thing because you can either join like a lot of universities. I know Monash has a formal mentoring program where the oldies put up their hand to mentor the youngies. But I've also found that just asking people for mentorship is a really good way to do things. And sometimes your mentor is right in front of you, but you don't actually recognise that. Like my son did an honours year, and there was one of the people that he was working with who showed quite a deal of interest in the work that he was doing and tried to give him suggestions. I said, Ben, why don't you ask this guy to be your mentor? Oh, no, Mum, I can't do that. I said, why not? He seems like a nice guy. He's probably, all you need to do is, meet a couple of times, have a coffee, and certainly, mentorship doesn't need to be such a formal thing. It can be, but, my relationship, for example, with Kate, I'd ring her up and she'd listen to my problems. She was a bit like a therapist sometimes, but she'd listen to my problems, give me some brief advice, and that was all I needed, a little bit of coaching, a little bit of assistance. Different mentors give you different things. Don't hesitate to just ask people to be your mentor. They can only say no, right?
Yep.
Thank you for that fantastic talk. I'm a junior doctor, and I recall when I did a rural rotation in a hospital, I found the slide actually really interesting about the abortion desert you showed, because I think the hospital I was in one of those areas. And it was a situation where a young woman wanted a surgical abortion, and the surgeon at this hospital was willing to do it. But unfortunately, the anaesthetist, I think they were the only trained anaesthetist at that hospital. For personal and cultural reasons, they didn't feel comfortable delivering that care. And I think, unfortunately, that woman had to go elsewhere for the care. So I guess I wonder, compared to medical abortions and, I think surgical abortions, it sounds like there's a few additional steps and teams involved. Is there a push for GPs in rural areas to, I guess, undergo anaesthetics training or, I guess, from a collaborative perspective, try and find ways to improve access in these areas that are already, the access is already very difficult?
Thanks for that question. It's a really important policy question, and in Victoria, it's we're very lucky. We've got a health minister and a premier that's very committed to improving abortion access in this state. And one of the problems is that it can be, at the moment, it's delivered in a very ad hoc way. One of the examples, when I talk to the policymakers, I say, if you think about cancer, for example, think about how cancer is planned for by the state in order to be able to deliver the necessary services in each region. There's a real planning process that goes on there to be able to provide those services. If we can do that for cancer, why can't we plan similarly for abortions at a regional level? If that anaesthetist has conscientious objection, then another anaesthetist has to be found to do that. Medical abortion is has already reduced the demand for early surgical abortion, but we will always need surgical abortion for women who have fetal malformations at a later gestation. And there are also many women who can't and shouldn't have a medical abortion. Women with psychiatric problems, homeless women, women experiencing family violence. It's not like they can go home and just take pills at home and have the medically induced miscarriage at home. They need to have a surgical abortion.
All right, if we don't have any more questions, we'll just join me in thanking Professor Mazza again.